Thanks, Dr. Wells. My name's Sarah Hopkins. I'm one of the child neurologists at the Children's Hospital of Philadelphia, and I'm going to talk a little bit today about the diagnosis of AFM and emergency department management. I'm going to be a little quick with some of the diagnosis stuff because Dr. Wells already covered some of that really nicely, so I'm hoping we can get back on track. So first, I want to thank the organizers for having me. I'm really happy to be here. 2020 has been really a bit of a crazy year already, so I'm hoping that you can take some of this information back with you to your home institution, so it'll help at least if we have an increase in AFM again this year. In terms of objectives, I wanted to review the typical presentation of AFM and focus a little bit on the neurologic exam for clinicians and specific key findings that are really important to diagnose, or to document rather, both for following the patients over time in the hospital and for classifying cases down the road through CDC. I want to summarize the initial monitoring, consults and testing recommendations, and also review some of the steps in diagnosis and talk about the basics of making triage decisions really when patients get admitted to the hospital. So the initial presentation of AFM, you all will be able to say this in your sleep by the time we're done with this. So AFM is suspected when you have the acute onset of flaccid weakness, with or without neck weakness, swallowing weakness, cranial nerve dysfunction, usually in the setting of a recent illness. Patient may have had a fever, had the fever go away, and sometimes had the fever symptoms come back. And meningeal signs, which are typically things like pain in the head and neck that we see when patients have meningitis, and also pain in the extremity that ends up being the one that gets weak. The weakness typically has asymmetric onset. I did see a question in the chat earlier. Someone was asking about what are the differences between TM and AFM. And one of the differences, well, a lot of us would consider AFM to be a subset of TM. One of the main differences is that AFM is typically asymmetric when it first comes on and doesn't tend to have a lot of sensory abnormalities, whereas transverse myelitis is not entirely symmetric, but somewhat more symmetric, tends to have more symmetric sensory abnormalities as well. Either of them may have bowel or bladder dysfunction at the time of presentation. When we see a patient who has AFM and do the initial exam, the things that we look for are from top to bottom. The first thing we look for are cranial nerve abnormalities. About 1/3 of AFM patients have those. These can be difficulty with eye movement or facial paralysis, but most commonly are things like trouble with elevating the palate, swallowing, and neck weakness. The muscle tone in the most affected extremity is typically low. It's usually flaccid or floppy, which is, of course, how AFM gets its name. And we'll talk a little bit more about that in a minute. Muscle strength, as Dr. Wells mentioned, the weakness is usually proximal greater than distal, so the patients have trouble doing so big or giving a high five to you in the emergency department. When you document strength, we typically will document strength against gravity, raising your arms against gravity or against some resistance. And it's important to be as descriptive as you can about that so people can follow that weakness over time. Deep tendon reflexes are typically lower absent in the most involved extremity, although they can sometimes be transiently a little bit increased at the onset of symptoms. And again, documenting these findings is essential for a couple different reasons. The first one is that clinicians following the patient once they're admitted to the hospital need to have an exam to compare serial exams over time so we can see the trajectory and know what's happening and whether we're concerned that there may be progression to something like trouble with breathing, but also for case confirmation for surveillance, it's important that that muscle tone gets documented. One question I've been hearing a lot of lately is, what is muscle tone and how do you check it? And people wondering, if they would recognize low muscle tone when they see it. And I think in the setting of AFM, the extremity is usually pretty floppy, and it's usually, frankly, a pretty noticeable difference. But just for the people that are wondering that, so muscle tone is the low-level contraction that you see in a muscle at rest, and how a muscle resists passive stretching. It's tested by trying to move the arm or the leg that's in question while that patient is distracted. So they're not focusing on tightening that muscle at all. You'll see neurologists sometimes do this. We'll talk to the patient and we'll take their hand and kind of move their arm and their wrist around, and that's what we're doing there. And really, I wish I had something to tell you that could be a guide for you to test this, but really the easiest thing is to just start testing it on a regular basis, and it won't take long at all until you'll get a really good idea of what is normal muscle tone, what's low, what's high. And then of course strength is different from muscle tone because strength is the force that a muscle generates against resistance. So we've talked a little bit about other diagnoses to consider. Patients with ADEM do not generally have what we would call encephalopathy or altered mental status unless they've got a super high fever or they're very dehydrated. So that's a red flag, as are kind of widespread sensory abnormalities might suggest another diagnosis. Two diagnoses that we like to keep on the list as well to consider are these two neuromyelitis optica and anti-myelin oligodendrocyte glycoprotein antibody-associated demyelination, or anti-MOB. So those are both neuroimmune conditions that have separate kinds of treatment that would be different typically from what we use for AFM, or sometimes from what we use for AFM. So those are tests that both have an antibody serum test that we can check, and so we typically check those to rule that out. Next steps. So after you've done your history, you've done your physical, and you really do suspect that this patient has AFM, the next steps, and really you're thinking about these all along, are to assure safety. So things that we can see in patients with AFM are autonomic dysfunction, which causes things like blood pressure and pulse fluctuations. So you want to monitor vital signs regularly. Bulbar dysfunction, we talked a little bit about, so that's going to be your neck and your swallowing weakness. We'll often consider making patients NPO, or which basically just means we're not going to let them eat for now because we want to be sure that they're safe to swallow without getting it down in their lungs and causing more problems. And then the other thing we really need to keep an eye out for is respiratory decline. And it's really important for first-line clinicians to know that patients who have bulbar or cranial nerve dysfunction or upper extremity weakness, particularly if it's recent onset, are at really high risk to have deterioration of their respiratory function. So we recommend monitoring pulmonary function testing, usually with a test called a negative inspiratory force, which generates how much air you can move every 4 hours at a minimum, and be wary of oxygen supplementation, because sometimes kids that are on oxygen have a good oxygen level and they can feel pretty good, but then their carbon dioxide is building up, which can cause further respiratory issues. Then next steps would be to consult key teams, typically neurology and infectious diseases, for additional help with kind of getting the imaging ordered and knowing exactly what infectious disease tests to send, and also consider consulting critical care at that time as well, if that's something you do in your hospital. So obtain key specimens is the next thing, and we'll talk about that on the next slide. And to consider diagnostic testing. So we usually recommend an MRI of the spinal cord and the brain, typically with and without contrast. Although sometimes in certain clinical situations, because we worry a little bit that sedation might make respiratory weakness more noticeable, sometimes we will consider from the emergency room just trying to send a more focused scan and then getting the full exam later. And then a lumbar puncture, because CSF can also help us think through the differential diagnosis. I added treatment to this slide, not because we really have a recommended treatment to give in the emergency room at this point, but because I hope you're going to learn about some new potential treatments today that we may want to be able to give sooner. So talking more about obtaining those key specimens early, this is a study from CDC that looked at patients with AFM presenting between 2015 and 2017 that was published in Pediatrics in November 2019. And basically, this is the yield of respiratory sample testing in these patients. And you've heard that we find enterovirus D68 and other viruses really more readily in non-sterile samples and not so much in the CSF. And you'll see the y-axis is the number of cases tested. The x-axis is the number of days from onset of limb weakness specimen collection. And really the optimal time to be collecting these specimens is day 2 or before. So we really encourage people to, at the very least, try to get that respiratory specimen when you're considering AFM in the emergency room. So even before you get to the point of having an MRI and a confirmed diagnosis, because it can really give us some additional information. You know, if it's enterovirus 71 versus D68, that may even help us be able to tell the family more about prognosis. These are the laboratory studies we consider. We have also a CHOP as Dr. Wells does a national kind of a protocol that we go by that's a little bit more extensive than this. This is kind of the basic. Of course, if there's one I had to pick, it would be those respiratory virus samples. But then we typically also look in blood, CSF for pleocytosis and protein. Protein can be somewhat elevated in CSF, and the cell count is often elevated as well. Those are both typically mild to moderately elevated, you know, a cell count of maybe 100, but we do have the rare patient who's up around 400 or 500 white blood cells in their spinal fluid. And then also protein is typically, you know, in the 80 to 120 range, but can be higher than that as well. At CHOP, because Lyme is endemic, we typically do check for Lyme disease as well, because it can cause spinal cord involvement. It's slightly different from AFM. And then, of course, in mosquito season, we typically will check West Nile as well. But those things will vary depending on the hospital and the location. Next steps after labs. So thinking about diagnostic testing, of course, the confirmed clinical diagnosis of AFM is really defined in part by this typical longitudinal gray matter T2 hyperintensities that I'm sure we'll hear more about from Dr. Murphy shortly. The lumbar puncture. We do want to minimize sedation if we can. Sometimes that's really not possible and we need the diagnostic information, but it's something to consider. And then it's also important to know that sometimes you'll do the MRI or the lumbar puncture, and if it's done really early, sometimes you don't see all the typical changes. So it's just important to keep that in mind and consider a repeat maybe around 5 to 7 days if that initial testing is negative. We do typically recommend that patients with AFM be admitted to the hospital, and with a rare exception, perhaps if they've been weak for an extended period of time. But really the reason for that is for close monitoring, because we know patients with AFM, while the onset is relatively acute, sometimes they will go on to continue to get weaker over the course of several days. And we also want to establish the diagnosis. and to get on top of things with rehab services. We consider the ICU for admission if there's bulbar, cranial nerve, or upper extremity weakness, if there are concerns from pulmonary function testing, or if the weakness seems to be progressing in the emergency room. So, and regardless of what service the patient is admitted to, close monitoring of vitals and respiratory function are essential. We typically will recommend a minimum of about every 4 hours on the neurology floor. And of course, it'll be more if the patient is in the ICU. So next up, I'm delighted that we're going to be learning more about neuroimaging and AFM from Dr. Olwen Murphy, who's a clinical fellow in the Division of Neuroimmunology and Neuroinfectious Disorders at Johns